Good morning, everybody. Welcome to yet another Zoom meeting. I'm actually going to get the date right this time, so that's kind of an exciting thing for me. And I'm double checking on my phone as we speak, but we are on the 6th. I made this on the 5th, so hey, we're on the 6th. That's a good thing. So today we're going to do something a little different. I actually do want to do more of an advisory. So we're going to talk about a clinical care update that we really need to think about. And of course, then we'll move into our question and answer and just general potpourri of fun. So we'll start off by talking about the advisory. So the Ohio Bureau of Criminal Investigation set out a public bulletin on the 19th of April talking specifically about nitrazines. And some of us may be familiar with this, some of us may not as much. This is not a common thing that we talk about, but I want to get ahead of it for you guys so you're aware of it and you understand what it means to you in your clinical care. So nitrazines are the potent synthetic opioids. It's a new class. And you're going to see what I mean by it as we go along here. These compounds were originally synthesized in the 50s, and they were all directed at pain management. And can we think of a better way of doing pain management? But in the end, these chemicals were thought to not be medically useful, and so they're not approved anywhere. And so we have a couple of which were placed as Schedule 1 drugs, and you can see those names there because I'm going to screw them up. But the one I kind of keep thinking about is isotonitrozine is the one I think of, and it's referred to often as ISO. And you can see the chemical compound on the side. That'll become important in another minute here, so we'll talk about that in a second. Before we touch base there, just to clarify for us what our Schedule 1s are, right? These are our drugs and substances which are defined as not acceptable for medical use and have an unbelievable potential for abuse. And I mean, I think we have our classic examples that we worry about: LSD, heroin, and so on and so forth. Now, what we found, which is interesting, is that these synthetics have really taken over. So in this graph, what you see is the US drug overdose death rate on the vertical, and on the horizontal, you have time, right? And what you see here is you can see that, well, the common players that we think of, our cocaines, our heroines, they're down here. But look at this, our synthetic opioid, and they excluded methadone here. The synthetic opioid has shot up. So in the end, though we have started to control deaths from heroin and definitely prescription opioids have significantly decreased. That's been something that has been a huge change, but we see a huge increase in our synthetic opioids, particularly this class. Now, when we think about this class, it started back in the 50s and 60s, but they've slowly started appearing. And more recently, we've seen a huge hit of a whole bunch of new ones which are coming up into play here. And this is of concern for us. So over the last 2 years, that's been the time point that we've seen a lot of increase in these substances. And these have actually been found in different items. And also they found a number of individual nitrazine compounds themselves. So what the Bureau of Criminal Investigation will do is, of course, they'll take any of these chemicals that they find, they'll run it through an HPLC and a gas chromatography, and what they'll identify is they'll identify all the components which are in there. And so slowly, ISO and these others have been increasing. So as of April 6th, the governor basically said that these are a bunch of new Schedule 1s, which are all the same derived classification. The problem is that, of course, these are largely unregulated. So we don't know anything about these. The real problem is that they can be made inexpensively with legal substances. So if you look at this compound, the reason that we have so many of these is that they're just small switches in these groups on the external pieces, R2 and R3. And so they're just small changes in these methylated or nitrogenated areas such that the chemical becomes slightly different, and now you have a different piece to work with. The problem is it's really easy to make in that sense. So when we've looked over time, so these are quarters 2021, 2022, 3, 4 for 2021, and now into 2022. And you can see that we've now had a spike of nitrazine cases reported statewide. And so the question becomes, what do we need to worry about? Well, then they broke it down to the specific items. And so you can see that all of these little players are somewhere in the system, but metronitrazine is the one that took a big hit. So somewhere along the way, somebody's been producing this. But when we think about all of them, these are all the ones which are the new schedules that we have added to our system. So these are all Schedule 1 drugs. When you're on the scene, does it really matter? Well, I guess you could look at it, and there's some specific observations that they gave us, that the Bureau gave us. And I am less than excited about these observations, because it's like, okay, it could be white, it could be off-white, it could be beige, it could be tan, it could be black, yellow, blah, blah, blah. It could be anything. It could be a powder, it could be a solid, it could be a liquid in syringes. You are not helping me. But that's probably because it's more often than not, it's mixed in with other things. We really don't have a really good beat exactly on how to identify nitrazine, except for within a laboratory. But I'm going to tell you the clinical manifestations of this in a second. The last thing I want to talk about is, where is it? So this is as of April. This is where the Ohio Bureau has identified the cases. And you can see it's a big hit in Montgomery County, but definitely different areas like Allen, Richland, Summit, Lucas, a little bit Scioto down here, which have been hit. Around us, I mean, there's been a couple of findings, low numbers, 3 to 4 in Marion, Union, and Franklin. But let's be honest, as we see it happening around us, it'll probably make its way towards us. So in the first quarter of 22, the lab saw 82% of cases containing nitrazine compounds also contain fentanyl. So we know there's a mixed bag going on here. In the most recent studies with nitrazine, what they found was it's probably 1.5 to 40 times more potent than fentanyl. So this is almost another pseudo-carfentanil type of thing, but it's a different class in that sense. And so the potential for abuse, addiction, and really respiratory depression and death is super high. So when we think about our clinical goals, as in all drug-related cases, I want you to use lots of caution. We need to do proper personal protective equipment. With the fentanyls in the past, we did not find that those were significantly linked with bad outcome in providers, though there was definitely lots amount of fear around the carfentanil piece. Now, the priority, what's our priority? Well, even with carfentanil, when we were talking about that medication, and now even with the nitrazines, airway management is our priority, right? So when you come on a scene with someone who's altered unconscious, we want to reach for the naloxone, and that's the right thing to do. But at the same time, the right thing to do is definitely don't let them be hypoxic or apneic. Give them airway management. Now, lots of options for this. I think we've talked about this in detail. You can just give them a good bag valve mask till you give them a little bit of naloxone and wake them up and go from there. The challenge with this particular medication is that we definitely know that it's going to take a lot higher doses of naloxone than we're used to. Also, the additional doses of naloxone may be required to reverse overdose involving nitrazine. So this further complicates the catch and release concept, because with this medication, you may be able to wake them up with naloxone, but it doesn't mean they're going to stay awake. And so there is a propensity for these people to drop a little bit more. So a lot of the things that we think about when it comes to the use of naloxone in the field for airway management is still true. If you want any more information, or you want to really get into the depths of this concept and really want to think about all the different aspects around this, we wrote a paper, which was the evidence-based guidelines for EMS administration. I'm one of the authors on this. And what we did is we looked at all the evidence around the use of naloxone and what are the best behaviors that we can follow. As of now, within our protocol, we've included those behaviors. So more than anything else, I wanted to touch base on this, give you guys an update of where this is coming from. Do I expect this to hit our streets in the next couple of days? I do not. But more than anything else, I want you guys to be aware and to have the information that you need. With that being said, open to questions about this or anything else. Quick and easy today, guys.
So do you think we're going to add more Narcan to our truck? We don't have a significant amount on our vehicle right now.
No, I completely agree. I think right now, I think we're good where we're at. This is not something, even carfentanil, when I look at our monthly numbers, what we look at is we actually follow the amount of naloxone. And actually in the last month's report, we even looked at it there, and we're barely using it at this point. And so I'm feeling pretty comfortable about where we're at. However, this is why I kind of stay on top of this, is that if we see it coming into our area, that's when we'll probably start talking about adding some more, and keeping in mind that the go-to, even if we can't wake them up with naloxone, hey, airway management, right? So you always have the total cure of airway management to stabilize and protect the individual. But you're right, the naloxone is a very big key in this. I will have to say, with nitrazine, one of the challenges that I've heard from the grapevine is that even when you give naloxone, you still have huge challenges with them going back down. Great question, Keith. Thank you.
The information that the BCI has, is that from people that have died? Or how'd they get that info?
So that is actually from my understanding. So I might be completely wrong. Always caveat. My understanding is that's actually from what's seized and what they've gotten. And so then they test them, test the drugs themselves, right? To see what the drug mixes are and things like that. So I don't think it's only overdose. I think it's also what's seized. So that way they know what's on the street, right? So their goal in this, and I love your question because I see where you're going with this, does it have a higher propensity of killing people than what we are used to seeing, right? And I'm not sure we know that answer. I think we know that it's very similar to carfentanil. Its potency is going to be a real problem, but their goal was to see what's actually hitting the streets and giving us warning beforehand so that we're prepared. Great question. So for now, doing your max of 4 milligrams is totally reasonable. Because remember, if you're hitting your fat max of 4 milligrams, I'm sorry, I should have caveated that. There's a question in the chat. Are we going up to our max of 4 milligrams or just to do a variance? Both approaches are not unreasonable, especially if you're starting to get a response from the patient. And so you can move towards a variance if that's the case. But let's keep in mind, if you're already at 4 milligrams, you better be managing that airway, right? That's one of those situations where that airway definitely needs protection because you've already hit 4 milligrams. The reason that we max it out at 4 milligrams, because at that point, you need to start thinking about a much larger differential diagnosis for the cause. It's like, I think we all know the tenet. If you keep doing the same thing over and over again, it can be insanity sometimes, right? So the question then is this person having like a pontine stroke or something like that, which mimics that of a substance abuse overdose? And so kind of open up that differential diagnosis as you start hitting the 4 milligram overdose numbers. Great question.
Dr. Panchal.
Yeah, fire away.
When it comes to the Narcan and the use of this nitrazine, if they have a propensity to go back down, how do we know that the drugs that they took contained this? And so we're like, in the past, hey, you took some heroin, okay, you were okay, you had somebody watching you for the next 24 hours.
Yeah.
How do we differentiate that?
I don't think we have any way right now, which is why the descriptions of what they're observing and what they're seeing on the chemical is very unsatisfactory for us, right? Because it's so non-specific that the ones that have mixed in nitrazine are not identifiable by us. That really complicates our decision making. There's no easy answer here. So a lot of those, like some agencies have true catch and release protocols where they're like, yeah, I gave you a little bit, here, go home and get out of here, right? And those are like some solid protocols that people have been using. And what we found, and we put this in our evidence-based guideline, is the data around catch and release is pretty bad. It's actually one study, which was from the 1990s or 2000s. And let's be honest, the drug milieu now has changed dramatically. We have so many different weird stuff out there, and the mixes with fentanyl are out of control. So we really don't have good data to suggest that the catch and release is perfect. I'll be honest, I think in a lot of situations, the wake up and go may be appropriate for some situations, but the problem is, especially if this goes up more, that's going to become much more of the rarity. It's going to be more of a transport and let them kind of get observed for a couple hours. In the ED, if I have one of these people come in, normally I observe them for 3 to 4 is what I normally do. And not my favorite people to observe, to be honest. they tend to be a little agitated at that point because they've gotten their naloxone and they're not so happy.
Dr. Panchal,
Yes.
I have a question. If they're seizing, is it more advantageous to give them the Ativan, or, I mean, the question is, do you want to wake them up, and just manage the airway? Because if they're seizing, go ahead and give them Ativan, and that should take care of it, or give them the Ativan and the Narcan.
Wow. Great question. That's complicated, right? Because the other problem with naloxone is that it actually decreases the seizure threshold. So I would probably reach for the Ativan. Again, I would not say that recognizing naloxone decreases the seizure threshold is part of our scope of practice, to be honest. I think that's a really complicated case. I think in that case, it's give the Ativan and manage the airway as best you can, right? Because then the question is it really an overdose, right? So if they're seizing, that is not the most common presentation for a substance abuse overdose, right? Especially an opioid overdose. And so I think at that point, the airway becomes really critically important because you're going to have to, you may be redirecting for other reasons for seizure, may it be bleed in the brain or other malignancies or things like that. Great question.
Does the presence of this nitrazine cause pinpoint pupils as well? Or is it?
Yeah,
Just
you're completely correct. It'll function very, very similar to what an opiate looks like. And keep in mind, it is often adulterated or be the adulterant in fentanyl. So you should expect a lot of the same behaviors as fentanyl.
Is this such a new emergence that they have yet to come up with street names for these drugs? So if somebody says, yeah, you took fentanyl mixed with blah, 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 we know what blah, blah, blah is.
The only street name I know is ISO, but then again, I'm not all that streetwise, I'll be honest. I think I need to get my lingo going, but ISO is the only one I've heard of as a dedicated street name. The rest may be so new. I don't know.
But being around at OSU, being around those college students, I figured you'd have some lingo.
No, I'm not that good yet. Hey, maybe we should have a little sweepstakes and name them ourselves.
Bodie McBoatface.
Well, guys, thank you so much for the awesome conversation. I mean, this is a brand new thing, but I just want to keep you guys aware of it. I don't think it changes our practice at all right now. And of course, we'll keep a close eye on what's happening with opioid use in our area, as well as how much naloxone is being used by the agencies around us, so that we kind of have an idea and a heads up. But I wanted to get this out to you once I heard about it, so we're all kind of on the same page. And so with that being said, we'll wrap up my part, and I'm going to pass it over to the chief.